Hello and welcome to Addressing the COVID-19 Crisis, a open forum webinar series for pharmacists. I'm Michael Hogue, President of the American Pharmacists Association and Dean at Loma Linda University School of Pharmacy. I'll be your moderator for today's program. We are so excited today. We have the opportunity to hear from an individual who has personally experienced COVID-19 and has had to adjust mitigating that in the pharmacy. So we're going to talk about how pharmacists can mitigate the impact on patients and other pharmacy staff in the event that they test positive for COVID-19. And we know that there have been pharmacists and pharmacy technicians across the country who have been exposed and tested positive for COVID. In fact, we are aware with sadness that there are some who've lost their lives as a result of this deadly virus. We're thankful today to have Roger Paganelli, who is joining us. He's the owner and supervising pharmacist at Mount Carmel Pharmacy in the Bronx, New York, which at the time that he experienced COVID was in the midst of the worst part of this outbreak and epidemic. He is also a luminary of CPESN in New York City. He's a third generation pharmacy and a pharmacy owner and co-owner of this pharmacy. And I also want to acknowledge my good friend John Beckner from the National Community Pharmacists Association for helping us to connect with Roger today, and we're thankful for NCPA's partnership on so many things to advance pharmacy practice. We also are going to be joined today by APHA's senior lobbyist, Alicia Carey Micah, who's going to share with us what's happening with provider status. In fact, we'll lead off with that today because we want to make sure we've got plenty of time to discuss Roger's story and to hear stories from our audience as well. And as always, we have other bright stars on APHA's staff who are joining us. Dan Zlott, who's Vice President for Professional Education Resources at APHA. Dan will be sharing clinical insights as questions come in from the audience, including those questions that we've received prior to today's webinar related to clinical matters. We'll also be joined by Elisa Bernstein, who'll be sharing more about the advocacy efforts beyond just provider status that APHA has been involved in over the course of the last week since we met last week on our weekly webinar. So a lot of information to share today, lots of good stories to tell, and lots of good information to get out there. We're going to start out, as I said, with Alicia Carey giving us a provider status update, a little bit of what's going on at the federal level, including what we need all of you to help with in moving that forward. We'll do that relatively quickly and then move into our conversation with Roger Paganelli so that he can share his stories from his community pharmacy in the Bronx. And then, of course, we're taking your questions. Now, just to orient everyone on how this works, on the GoToWebinar control panel, there are several things I'll draw your attention to. First of all, the handout for today's webinar is located under the Handouts tab. You can download that and actually keep a copy of the handout. All of the links that are provided in the handout are active, so you can just click on those and go directly to the resource that we've provided for you. You also should know that this webinar is being recorded and it'll be available at pharmacists.com in the COVID-19 resources section. Just go to pharmacists.com and at the top you'll see COVID-19 banner. You click on that banner, it takes you to all the resources, including the past episodes of this webinar and today's episode as well. Now, we do love to take your questions. The best way to do that is for you to type in your question in advance in the question box. Go ahead and type those in as they come to your mind so that you can get in the queue. If you have multiple questions, no problem, just put those in the queue. If you have audio capabilities, then we will actually call on you to ask your question at the right time during the webinar. Now, here's the key. If you're connecting via your computer's audio, it's a very simple process. You'll just unmute your line by clicking on the microphone icon. It'll turn green when it's open, but the staff on our end will have to unmute your line as well because we have so many participants that we have to mute everybody's line until it's time for you to speak. For those of you who are joining on a cell phone or a landline and you want to ask your question verbally, you'll need to go ahead and enter your audio PIN as provided by GoToWebinar in order to be able to speak or for us to be able to unmute your line. And if you don't have audio and you just want to make a comment or you want me to read a question on your behalf, just say no audio when you type your question in, and I'll take care of getting that comment in. Also today, I just want to point out that we're going to be covering a lot of information about personal experiences with COVID-19, and that is critically important because how we each experience COVID-19 is going to be a bit different in our own practices. It would be wonderful if we have people on the phone who would also like to share briefly their experiences with COVID-19. There'll be a chance for you to be able to do that. And we're happy to maintain your anonymity if you want to share a story, but don't want to reveal who you are or who the people involved are because of protected patient information. We'll respect that, but we will provide an opportunity for you to be able to share that story. I can share it if you type it in, or you can share it verbally and we'll unmute your line and let you be anonymous to the extent that you wish to be. So we share that with you as well. And then as always, we refer you to the CDC's website for the current guidance and guidelines as it relates to dealing with positive COVID-19 tests among your staff. And that includes your pharmacists or your technicians, and CDC keeps that up to date pretty well, so we encourage you to take a look at that. So with that, I would like to go ahead and start by asking Alicia Carey Micah to join us. Alicia Carey, thank you so much. We're so excited to see that provider status seems to be gaining some momentum in the U.S. Congress, and we'd like to have you tell us a little bit about that. Go ahead, Alicia Carey.
Thank you, Dr. Hogue. So as a reminder, I just want to put it out there that provider status means the recognition of pharmacists and their services by payers. And most notably on the federal level, that is by Medicare, and that's the area that we focus on at APHA. Over the past few years, our efforts to secure payment for all pharmacist services allowed under your state scope of practice in Medicare have not passed through Congress due to a couple of reasons. Number one, and most important, is the Congressional Budget Office, who is an independent, nonpartisan agency who studies the economic impact of legislation, scored the bill, and it gave it a very high price tag. And unfortunately, many in Congress were uncomfortable with spending such a large sum of money on this issue. Another source of opposition that we have faced has come from the American Medical Association. And the AMA has a lot of sway on Capitol Hill due to the massive amount of money that they spend on lobbying Congress, along with the very large PAC that they have. And I'll get back to the AMA in just a minute. Since March, when the pandemic was declared, we have been in constant communication with Congress to figure out a legislative solution for Medicare to pay pharmacists for COVID-related services. However, our efforts to get payment for pharmacists who test and treat for COVID and influenza were stopped in the 11th hour by the aforementioned AMA due to their disapproval of this. However, since then, we've had discussions with the AMA via members of Congress to move them to a neutral position on a legislative fix to pay pharmacists for testing for COVID and flu. This plan is in part of our strategy to overcome the barriers we had back in March when the first CARES Act was passed by Congress. And by changing the AMA's opposition is just one piece of this. We obviously need Congress to also act. So while they appreciate that there is no outside opposition to the provision we're asking for now, the scaled back language, the testing, they have expressed to us that they need to hear from constituents who want this legislation. And unfortunately, there's only been 2 members of Congress who have told me that they've heard from pharmacists on this. I know that more of you have reached out to your member of Congress, but we need a groundswell, and they need to hear from numerous people on the same issue to make an impact. So I know I've said this for many weeks, but we really need you to step up the outreach to your members of Congress. The next bill to address COVID is being crafted by Congress and congressional leadership and the White House right now. They hope to get a deal by this weekend if they are able to. They're still pretty far apart, but APHA doesn't have a very big PAC, and our allies in the pharmacy community really rely on grassroots outreach to Congress to achieve our goals. So we posted a grassroots alert asking for pharmacists to call your 2 senators and your member of Congress, along with congressional leadership who are crafting this legislation. And that includes Senator Schumer from New York, Senator McConnell from Kentucky, and Speaker Pelosi from California. The alert contains all the information on how to do this outreach. The APHA staff are also happy to help if you have any questions. And in a couple of slides you'll see, and I'll tell you where to find it on our website. So that's kind of where things stand right now with this provision, which is, again, it's Medicare payment for testing services. It's not in the Senate Republican or the Democratic House proposals that have been released to the public right now. So in order to change that, and in order to get it into what they're going to hopefully pass in the next week or so, we're trying to put out a lot of pressure on them here in DC, but we also need more pushes from pharmacists around the country to make this a reality. So we understand that the language is currently being analyzed by the Congressional Budget Office, and that several senators have requested that they put that on the fast track. So we appreciate those asks that I know some of you have made to congressional leadership about that CBO score. So that's kind of an update on that. So that's a quick overview of what we've done since March and where things stand today. I'll be happy to answer questions at the end, but if you don't mind going to the next slide, Brian. Actually, the previous slide, that one, it shows we had a letter sent yesterday, I believe, maybe on Tuesday, with a bunch of non-pharmacy groups who are supportive of this issue. So we hope that the outside support will also help make a little bit a dent in the support that we have on Capitol Hill. And then the last slide is the one that you put up for the grassroots alert. So thank you. This, if you go to the advocacy section on our website, you'll see a button to click on the Action Center, and it walks you through. You can either call your member of Congress and it'll help patch you through to your member and to Senator Schumer and McConnell and Speaker Pelosi, or it'll help you email them. So thanks for all of your support. And like I said, Michael, I'm happy to answer questions either now or at the end.
Well, this is great. We'll allow you to go for now, and we'll bring in questions as we open up the lines a little bit later in the webinar. But I think this is such important information. Folks, we are standing at the 10-yard line. It's time for us to get across the goal line with provider status in Congress. We need each of you taking time today to call your member of Congress. It's a very simple thing to do. It's very painless, and I know sometimes pharmacists are a little shy and don't like to make those phone calls, but we're going to ask you today to do it for your profession, to actually pick up the phone and call your member of Congress or your senator and ask them to support pharmacist provider status for COVID-19 and influenza. So very important, and thank you for doing that. Well, now let's get on to our guest speaker today. Roger Paganelli, thank you so much for taking time out of your schedule. I know you're on the road today, and just thank you for taking time to be able to visit with us.
Hi, Michael. Thank you very much. Sorry, I had to unmute there. Appreciate the opportunity to be here and to address this audience. Thank you again for inviting me on.
Thank you so much. Now, your pharmacy is located there in the Bronx. Give us just a little bit of a snapshot picture of your pharmacy. You're a traditional independent pharmacy, I take it.
We are indeed. We have been in the same location for close to 100 years. My family has owned Mount Carmel Pharmacy for approximately 60 years now. And we are, just as you said, a typical corner drugstore in urban New York City, highly densely populated area, ethnically mixed neighborhood, and just bustling all the time with people on foot.
I know you can't see this, but we've put some pictures up for our audience to be able to see Mount Carmel Pharmacy, and it literally is a corner drugstore right on the corner of the street there. And so you really have that, and we can see your advertising there that you're not only providing medications, but you're also doing PrEP therapy and Narcan and HIV testing and other things. And so you've got quite a great practice there. I guess my next question to you is that when the COVID-19 crisis first hit New York, what were some of the initial ways that your pharmacy responded to the crisis? Just getting started there.
Thanks, Michael. So one of the first things that we decided to do was the curbside delivery. We immediately put a table out front, and in one of those pictures you can see that we have, I call it a kiosk. It's a table. We made a covering for the table. We never had that before. It has our phone number on it. It has our text number on it. And we immediately set up 2 lines in front of the store and took advantage of the fact that we are truly a corner drugstore, where we formed a line on one side of one aspect of the sidewalk for folks coming to pick up their prescriptions and needing to speak with pharmacy staff, and around the corner was for all other essential items that were non-prescription. We put our computer outside so that our technician at the computer can access our will call bag system inside, and a telephone as well, and there would be constant communication back and forth. Made sure that any of our employees out there had PPE on, protecting themselves and protecting the clientele. And I mean, that's what we did on the outside of the store to immediately mitigate exposure. And then we did something. Go ahead, Michael.
Oh, sorry. On the outside of the store, one of the photos that we're looking at, it looks like there are some metal cordons, much like we'd expect the police department to use to keep people in line. Did you have cooperation from NYPD to help you with crowd control and those sorts of things, or how did you acquire that? Very practically, how did you acquire that to be able to keep people in a straight line and 6 feet separated and so forth?
Thanks for recognizing that. We absolutely had buy-in from the police department. We called the community affairs office. They came out the same night, and they gave us about 50 feet of railing there. And we did the 6-foot tape on the ground. You might be able to see it if you zoomed in there. We put red tape, again, on both aspects of the sidewalk so that the people would maintain their distance, or we would, that was what we were trying to accomplish. It did take some communicating. So eventually we put somebody out in front of the door to manage both lines, along with the person at the kiosk there to manage the people and their requests.
So in the area that's around your pharmacy, I would assume that there are thousands of people who live in this area. You must be the healthcare provider essentially for your part of the city.
Well, it's interesting. The inner city of New York is a completely different animal than most places on the planet, insofar as how many pharmacies there are. I think we have more independent community pharmacies in the country than any other state, somewhere in the 25 or 2,700 range. And there are, in some neighborhoods, there's literally one on every corner. So then you take into account how densely populated our areas are. I call them vertical people because there are so many apartment and tenement buildings where people are just stacked, one family on top of another. And then there is the multi-generations living within that same apartment, and so on and so forth. So it's a really intense, we're part of the fabric of the community, but there's other local pharmacies as well. There's a chain, there's a couple of independents, and all of us do our part to take care of the needs of our community.
Well, Roger, you certainly, as your sign says there, have been hero healthcare providers through this crisis in the epicenter of what was the early part of the pandemic in the U.S. Now, you shared with us and have given us permission to share with the audience that you personally actually did test positive for COVID-19. Can you just briefly outline for us, when did that happen? How far into the pandemic did you test positive? And maybe if it's not too personal to share, just tell us a little bit about your course of illness.
Sure. Let me just start by kind of laying out what our operation looks like inside of that the corner there. We have approximately 40 employees there on top of the 3 ownership, myself and my 2 brothers. And we work in very close quarters. We've got 1,000 square feet of selling space. You can imagine how tight that is with all the clientele. And then we've got about 1,300 to 1,400 square feet behind the counter where all of the magic happens, all the pharmacy magic happens. And initially, one of my pharmacists was diagnosed positive, became very ill immediately with respiratory issues, and it wasn't much further after that. I don't know how many days. I want to say less than 5 days that I started to develop a cough, Michael. And I immediately, and in that 5-day period, my staff pharmacist, did test positive. So as soon as I started to cough, which was the only symptom I experienced, I went and I was tested at the hospital in the county where I live, the adjacent county in Westchester County. And I was diagnosed on March 30th, very early on in the pandemic in New York State. And I never went back to the pharmacy with the complete staff there. I removed myself and immediately set up my home office and started to work from there.
Well, that's really great. And I really want to ask you about that because, I'm sure many pharmacists, especially those who are owners who are on the phone, but even others may want to really hear about how you did that work from home piece. Because, we may not always think about the logistics of being able to do what we do as pharmacists from home. So tell us a little bit about that, because I think that's pretty intriguing that you were able, your illness was relatively mild to moderate, and you were able to recuperate at home. So you also decided to do some work from home. Tell us how you did that. How did you accomplish your task from home?
Sure. So fortuitously, none of it was planned for COVID. Obviously, nobody knew of this. We installed a VPN, which is a virtual privacy network, which allows us to maintain our pharmacy operating system or pharmacy management system remotely, so that I can share, that I can transmit electronic health records and protected health information and patient information over the internet in a secure way. And again, fortuitously, we had that installed, maybe operationally installed a month before this happened. And we did move to a phone system that's a video IP, a voice over internet, which plugs, you take your phone and you plug it into any Ethernet, and now you're connected to the phone system that's within the pharmacy, and you've got your pharmacy operating system in front of you. I had my security cameras on my second laptop or iPad, and it was as if I was in the pharmacy directing. And out of our 4 staff pharmacists, we only had one that did not test positive for COVID. So we were down to, and we're a very busy operation. We have thousands of people on our clinical medication synchronization program. So you can think about how many prescriptions and orders per day and how many phone calls we get and make on a daily basis. And to have one pharmacist there, they could not handle this operation on their own. So besides myself, one of my other staff, you'll see another photo in there, my director of operations, Javier, also had the same symptom and tested positive within a day of when I tested positive, and Javier set his system up at home. So we were able to support the business to the best of our ability remotely. But, you know, this COVID thing has taught us all, look at what we're doing now, how much this remote piece can be manipulated and be beneficial and work for our business model.
Absolutely. Roger, you've mentioned that all of your other pharmacists ended up testing positive for COVID. And I think I understand from you that several of your staff members also tested positive for COVID. Did that happen about the same time? I mean, did you have this occur, over a long period of time, people tested positive, or did your pharmacy have impact from COVID directly over a very short period of time?
It was relatively short, and we went down like dominoes. Some of my staff got very sick. Thankfully, nobody was hospitalized or had to be put on a ventilator. But my cousin, who's worked for my grandfather in his pharmacy, worked for my dad as a young guy in his pharmacy, and still works for us today, 67 years old, was really, really sick. And a guy who hasn't taken 5 sick days in 30 years was out for a month. My pharmacist, a classmate of mine, same thing, 23 years under my employ, not 2 or 3 sick days in all of those years, was out for 21 days on a nebulizer and just, incapacitated. And then the rest of my staff started to fall like that. And I've got a really good story to follow up with that. So hopefully I'll get to that on your next question.
Yeah. So my question really is, do you suspect that probably, I guess it would be a total guess on your part at this point, but are you suspecting, given the rapid nature with which everybody seemed to come down with COVID that works in your pharmacy, that perhaps it was exposure to patients? And that raises a question about personal protective equipment. Were you able to get access to it? It looks like from the photograph that you do have masks. So I'm curious to hear about your experiences with PPE. We had lots of people who were struggling nationally with PPE. So tell us about your experiences with PPE.
Sure. And like I think you alluded to, it's anybody's guess, who was the original vector. But I believe that all of our staff eventually became vectors to one another. And as far as the PPE goes, initially, if everyone recalls, and the rest of the country is getting this after New York and New Jersey got it, having those waves of COVID. So the mask information or the information about masks is so much more prevalent and understood, and there's some science and data behind it. But at the outset, masks weren't it. We were told it was a contact situation, so gloves were more important. So we weren't wearing masks at first until, and in my operation, everybody started to drop, so we started to wear masks. Absolutely. The PPE became such a hot item. Folks got arrested for selling things, gouging prices, and it was hard to come by at reasonable prices because you needed it for your staff. You needed to sell it to your customer base. And there were patients that needed it that couldn't afford it. And, and often, in many cases, we were donating masks. Gowns were almost impossible to come across, and gloves became difficult as the time went on. And gloves are still a little bit tricky right now. We're having a difficult time, spotty time finding gloves. So, yeah, PPE was was difficult.
Yeah, I've heard in the last 2 weeks, in fact, here in California, we're having some challenges right now with gloves. Gloves seem to be the most difficult thing for pharmacies here in California to acquire. Now, one of the photographs that we have up on the screen right now, one is a picture of you with a couple of your staff members. The other one is a picture of what looks like your pharmacy counter, perhaps, and it looks like you have some of your drug wholesaler totes stacked up there. What is that? Tell us about that. What's in that? What are we looking at in that picture?
So I'm going to go to the drug totes first. Those are the totes from Cardinal. And early on, before we could get the plexiglass, and I think you'll see it's difficult to make out the plexiglass picture. I don't know if that slides up right now, but prior to anybody having any plexiglass, my cousin, who I said initially came down with the COVID, said, "Hey, we got to keep the distance. At least keep that distance from the customers and the team." So he decided to put a couple of layers and stack the totes so that there was that 6-foot barrier, including the counter and the double totes, so that we were trying our best to keep the distance between those at the counter and those behind the counter. That's what that was. It was pretty ingenious, and that was our early on distancing program. Really crude, but really for us effective. Now the picture of I want to address the picture of the folks there, myself and Javier and one of my technicians, super techs as I refer to them as. I have quite a few of those. We were all diagnosed positive with COVID, and what we did was very unusual, and maybe there's some pearls of wisdom folks on this call can take away from this. Because I was not sick and sicker than a cough per se, and I can still work, I would work from home virtually, and then we would, at 7 p.m., the staff would leave the store, and me and my COVID crew would come in, and that's what you're seeing there. We were all positive, but fairly asymptomatic, and we needed to get orders out the door for the next day. Otherwise, I don't know what would have happened to our operation. So we would work through the night, typically from 8 o'clock until 1 or 2 or 3 in the morning, depending on what it took. And then I had a professional disinfectant company come in, and they would sanitize the entire store so they were ready for the morning crew. So we did a split crew, which is something we never did before. And don't use my model, but consider some of what I did for your operation if somebody does, and if you are short-staffed and you need to break that crew up and the people are positive but yet able to work.
Well, that's great, and thanks for sharing that. Now we're at the point in our program where we like to take questions from our audience. Folks, we're going to open this up to questions on any topic. You can make comments about your experiences with COVID-19 personally, if you wish. Again, I'm happy to make comments on your behalf if you want to remain anonymous, and I'll read your comments into the discussion. But if you have a question on any topic related to COVID-19, we have our full expert panel available to us today that can take your questions. I do have one comment that was made that the individual would like for us to make this comment anonymously. This is from a pharmacist who says, "I was diagnosed with COVID in early July. I provide pain management and addiction services in an outpatient family medicine clinic. Symptoms prevented interaction with patients, even remotely, for almost 1 week. This resulted in significant gaps in care for my patients. I strongly recommend my colleagues develop contingency plans for this scenario. Potentially identify a colleague that you could partner with to discuss especially complex current patients in your respective practices on a regular basis should your service need to be covered in the event of diagnosis with COVID-19. Wow, that is really an incredible story. And I think it helps remind us that regardless of where you're practicing as a pharmacist, obviously Roger's in an independent pharmacy, but this individual was in an ambulatory care setting. Regardless of your setting, we all need to be thinking, what happens if I, as the pharmacist, can't take care of my patients because I am the patient? I've become sick enough that I have to stay home. So definitely something that we all have to think about, and we all have to be vigilant about. So very important. Now, I do have a question for Dan Zlott. Dan, this is a clinical question that's come in this week. RLF 100 has been in the news recently and is reported to show a benefit in COVID-19. Now, I'm sorry, I'm a little rusty on practice. I'm not sure what RLF 100 really is, but Dan, could you just briefly enlighten us about what is RLF 100 and what do pharmacists need to know about it?
Absolutely, Michael. That's a great question. And that's a drug that's been in the news in a number of different sources in the last week or so. And so RLF 100 is actually an older drug, and I don't mean really old. It started popping up around 2016. It goes by a couple other names that you may recognize. One of them is aviptidil, also vasoactive intestinal peptide is the other name for it. And it's primarily been studied for acute respiratory distress syndrome or acute lung injury. And so, given the symptoms of COVID, with a lot of lung injury, in this case being done primarily by the immune system's response to the COVID-19 virus, you can imagine the attractiveness of studying that particular medication. So right now, it's odd, the only information that's available is coming out of news reports. So there's a news report coming out of basically Houston Methodist Hospital that a series of 15 patients have recovered well, and these were patients with advanced symptoms. But for now, as I said, those are just news reports. We're still waiting on the official data so we can review that and take a better look at some of the use criteria, the patient selection criteria, to get a better sense of what types of patients are candidates for this and who benefits the most.
Well, thank you so much. I appreciate that. We have another comment I'm going to read in. This is from one of our pharmacists, Kim Crowley, who's in Kentucky, and she says, Michael, I don't have a microphone, but I want you to tell Roger that he and his pharmacist crew are rock stars. Roger, you've inspired some of our pharmacists here. These contingency plans are absolutely necessary, and there are lots of amazing ideas out there. So Roger, on behalf of Kim Crowley, she wants us to just pass along to you her gratitude for you sharing your story today. Roger, I wonder if you have any take-home messages. Is there? I think one of the things that you did, when you and I talked prior to today's webinar, you mentioned that you also use some technology to communicate with patients using texting. I'd like to see if you could share with our audience just a little bit about what you did with texting to be able to ensure continuity of care for your patients.
Yeah, thank you, Michael, and thanks for the shout out there. And I think, when you're the first to get hit, you can either fall down and just lay in bed and be sick, or you can rise to the occasion. I like to think that not myself, but my staff are the rock star, and that's why we put those Hero Healthcare Provider signs up. So thank you for that. And about texting, several years ago, I want to say about 3.5 years ago, it was brought to my attention that there was a platform. The name of the one I use, and this is not, and it is a texting service where they use your main phone number as a textability, and it's interactive. It is two-way interactive, so that patients can text refill requests, they can text questions, they can text requests of any type, order over-the-counter items, And we immediately saw an uptick, probably 1,000%, in the texting area of our business. It was absolutely essential. That, along with, that technology, along with, had I not employed a medication synchronization program with the thousands of people that we care for every month, how would we have taken care of that? Like the healthcare provider in the ambulatory service, how would we have been able to do that without some of these technology fixes? I would look into a texting program where the text comes to the screen where the pharmacists are operating the business. And again, it's not an immediate thing, but it's an interactive thing where you can communicate with your client base and your patient base, and they get very comfortable with that. So leverage the technology to the max.
Roger, you mentioned the name of that service, but we heard everything you said except the name of the service that you were using. You broke up on that. Can you share with us again the name of the company or the service that you use for that texting?
Sure. The name of it is ZipWhip, ZIPWHIP.
Okay, ZipWhip was the name of that service. So thank you for that. And that was one of the questions we got in our box as well. So we appreciate that question. Now I'm going to change the subject again real quickly. Pauline Jacobs is listening today as one of our participants. Pauline, we're going to unmute your line and allow you to ask your question and make your comment about COVID testing.
So this was actually towards when you were looking for support from prescribers and doctors that were for the COVID testing. I received some interaction from a couple doctor friends that were asking about the sensitivity of the testing. They had some requests from nursing and other areas from the nursing people in school. And they wanted to make sure that the testing had certain specificity and that people weren't ignoring false negatives, or the testing had certain, there were guidelines to that.
Yeah, Pauline, thank you so much for that question. It's great. Sensitivity and specificity of these tests, as we've talked on several of our previous shows, are very, very important. And pharmacists will need to be sure to disclose that. I mean, I will share a personal experience that, several weeks ago, I had a mild cough and some allergy type symptoms, but in today's world, I took the chance and got tested. I was very interested to see that when I got the results of my test, which was negative, by the way, they actually did disclose to me the sensitivity and specificity of the test that I had received. Dan Slott, is that the standard? Should pharmacists who get involved in testing be prepared to disclose to their patients the sensitivity and specificity of the test that they're conducting?
Pauline and Michael, that's a fantastic question. And I think the answer is absolutely yes. And I think also to be prepared to discuss what each of those numbers mean. So sensitivity is basically your true positive rate. So the ability of the test to detect the presence of the virus in patients who are actually infected with the virus. And then specificity is the opposite. It's the true negative rate. It's the false negative rate rather. So at what, how often does a false negative occur, essentially? And so being able to explain to a patient the idea that just because you test negative, there's still a 5% chance, 10% chance, whatever it may be, that you may actually be positive. So you still need to, be cautious and then take appropriate precautions.
Now, Dan, while we've got you here, we also received a question in advance of today's webinar about some news coming out of the NIH relative to increasing testing capacity nationally. And obviously that's one of the reasons we as pharmacists are asking for provider status. But can you tell us a little bit more? I think Francis Collins of NIH, even just today, blogged about testing. So can you tell us a little bit more about what we're seeing today, yesterday in the news about testing?
Absolutely. So this is a really interesting initiative coming out of the National Institutes of Health, and it's called their RADx initiative, or Rapid Acceleration of Diagnostics. And the idea is exactly what it sounds like, to bring new diagnostics to market more quickly. And the program itself basically is sort of the typical thing that NIH does in terms of funding research and funding development of new products and biomedical services, but in a very accelerated scale. So it's kind of broken down into 4 phases, which is the identification of good testing technology, the acceleration of development, the focus on scalability so that we can rapidly scale up tests. We've certainly seen that there are a number of tests available, but the ability to rapidly scale those up has not kept pace with the demand. And then lastly, the deployment. And in particular, they have a deployment focus on underserved populations. And so really an interesting platform to really drive forward point of care testing. I think I failed to mention that they're focused specifically on point of care testing for COVID-19. And so it's a really cool initiative. I'll drop a link in the comments here. The New England Journal actually did an article on this. So if you'd like to learn a little bit more information about the initiative and its various parts and pieces, I'll drop that link in the comments for everybody.
Well, this would also be a good time for us to mention to our listeners that next week we're going to be talking about testing again. We are going to bring in some frontline providers, pharmacists who are actually doing testing. We did this several weeks ago. It was one of our most popular webinars, is the week that we brought a pharmacist on who was actively engaged in testing. We're going to do the same thing next week. We're going to bring on a couple of pharmacists who are actively involved in testing and get their experiences. Some of them have done thousands of tests, and so we're really excited to hear their stories and a little bit more of how they've operationalized that in their pharmacies. And we think that you all will find that very helpful as you're planning. I also just want to mention that all of those webinars that we've done previously are available at pharmacists.com, and you can go back and listen to those. Now we're going to take one last question as we're running a little short on time here. Murti Savatala, you have a question. We're going to unmute your line and allow you to ask your question. I'll ask the question for you, and that is, now that we have a flu season coming up soon, how are we going to know if the patient has COVID or if they have the flu? Well, I think, Murti, you've asked the question that really begs for the answer of pharmacists. Pharmacists are going to help with this. We believe this is why it is so critical for Congress to act now to allow pharmacists to do both COVID-19 testing and flu testing, because really the only way we're going to know is if we actually do a swab and test the patient for flu and for COVID to determine if they come back positive for one or the other, or potentially both. And so it'll be very important that we have strong testing in local communities, and with the pharmacist being the most accessible healthcare provider, we strongly believe that needs to happen. So this is why we're asking all of you to act and to call your member of Congress and your senators today and to ask for testing to happen for pharmacists to be added as providers under Medicare for testing. Well, we have tons of other questions that I'm sorry we can't get to all of them. We'll try to address some of these questions and comments that have come in our Engage platform. And right now, I'd like to call on Elisa Bernstein to share some information relative to what's going on at APHA headquarters and in Washington as it relates to other regulatory matters and educational matters. Elisa, thanks for joining us.
Great, thank you. Glad to be here. So I'm going to whiz through a bunch of slides here and give you a really fast update because there's a lot happening. But first, I want to tell you, every week we tell you about APHA's 15 on COVID-19 series. We are up to 23 episodes now. Here are two of the most recent ones on dexamethasone and mRNA vaccines. And tomorrow we'll be releasing one on adenovirus-based COVID vaccines. I don't know anything about these, so I'll be watching that to learn more. Let's go to the next slide. Also brand new, as you know, we have if you've been watching, we have a number of APHA COVID practice resources that we've been continuing to develop over the last several months. And we just this week issued a new one that includes pharmacy models for COVID-19 testing. And this is really a kind of a step-by-step overview of two different of the main models that are used for testing. One is where a pharmacist would be collecting a specimen in partnership with a lab, and another where a pharmacy would be actually providing a point of care test. So there's a lot of information in this little resource. So I highly recommend that if you're interested in learning more, that you go to this resource on our Pharmacist Guide to Coronaviruses. It can be found there. Next slide. So what's been happening around the Hill and in regulatory agencies? Just this week, the White House, the president signed an executive order aimed at improving rural health and telehealth access. Basically what it did, so nothing actually happens when you issue an executive order. It directs an agency or some other entity in the government to do something, finalize a rule or do a report or do a study. And so what this did is it provided it called for increasing flexibilities for rural providers and increasing access to healthcare by eliminating burdens that limit the availability of clinical professionals. It also talked about supervision flexibilities for Medicare providers in rural areas. So APHA will be commenting on these and clearly, of course, advocating for inclusion of pharmacist services. And the next slide, please. Also, this week, really interesting is that CMS specifically announced that they will be using the existing payment codes to reimburse eligible providers for COVID-19 counseling services. For pharmacists to be included, they need to be in an incident to arrangement with physicians. So it doesn't matter where the test is done, but they have to be in an incident to in order for pharmacists to be included. Again, APHA is going to continue our advocacy efforts to get a legislative solution so we can get paid independently for these services. On the next slide, also, when every year CMS issues a physician's fee schedule proposed rule, and what this physician fee schedule does is it updates payment policies, payment rates, and other provisions for services furnished under the Medicare Physician Fee Schedule on or after January 1st, 2021. So a proposed rule was issued. This is what CMS proposes to do, and then they take comments and then they'll finalize it. And so what they're proposing to do and they have included a couple of different provisions related to pharmacist services. One is they restated that pharmacist medication management services are covered under Medicare Part B and D. They also restated that pharmacists are auxiliary personnel and talked about the services related to remote patient monitoring under supervision and how that would be paid. They also specifically, as expected in CMS, said that the clinical services shall be provided in accordance with the state scope of practice that has the limits and parameters over related to applicable law. And what this doesn't do, though, that we've been asking CMS many times, is to clarify and confirm that physicians can bill for using pharmacists for more complex evaluation and management and bill at higher codes. So we've asked for that clarification many times. They haven't, and we will continue to try and get that answer and clarity for you. On the next slide, what CMS also did in that rule is they included information about telehealth and immunization administration. What they reiterated that pharmacists can enter into incident to relationships and agreements for telehealth, and that the physician supervision can be provided virtually using real-time audio and video technology. So that's important to, again, include the parameters. They also restated that they increased the immunization administration rates for providers, which includes pharmacists, back to the 2017 levels, which would increase the amount when the flu and COVID vaccine is available. On the next slide, that's it for now. So I'm going to turn it back over to Michael. Thank you.
Well, thank you, Elisa. I want to mention to you all that you have the ability to connect with one another and to share information. We do have a COVID-19 Engage forum where pharmacists who are members of APHA can connect and have conversation about these issues between our weekly webinars. We try to post late breaking information on that page as it comes available, but it's also a great place for you to share your pearls of wisdom and your best practices from your practice with all the other pharmacists who are working on these matters. So we ask you to do that, to engage. There are engaged communities on lots of topics, but we're highlighting the COVID-19 group this particular week and asking you to consider that. Now, I also want to just take a moment to do something that we oftentimes don't take time to do each week because we're pressed for time. But because I have a little extra time this week, I'm going to take the moment to do it. I want to sincerely thank the APHA staff for their tireless efforts. I've, folks, gotten the chance to work with these ladies and gentlemen that are dedicated to our association day in and day out. The staff work tirelessly. They work long hours. They oftentimes sacrifice time with their family and with others to ensure that our profession's needs are met on Capitol Hill, and they love what they do. And so please join me in thanking the APHA staff for their tireless efforts to press our profession forward and to help us move forward on a day-to-day basis. We could not accomplish anything that we are making headway on at this moment if it weren't for the APHA staff. Lastly, we got a comment or two in the late breaking comment in the comment section that I want to point out, and that is several of you have said that when you've called the switchboard at the congressional offices, that it's been busy and you've not been able to get through. Let me encourage you to just Google your congressman or your congresswoman's local office, their district office. They will all have a district office in addition to having their office on Capitol Hill. Placing an office at a call at the district level is just as important and can be just as effective. So take time to try to find the phone number of your member of Congress and reach out to them today. We really do appreciate all that you're doing. I also want to take the last moment just to once again thank Roger Paganelli and all of the pharmacists at Mount Carmel Pharmacy and all of the pharmacy technicians and staff there for letting us hear your story today. We're grateful for having had that opportunity, and you've given us your insights and your wisdom, and we are very grateful for that as we go into this crisis. Thank you, everyone, for joining us today. Be well, and God bless.